We today have, let's say, a very well-established algorithm in acute GvHD, where we have steroid first line and we have ruxolitinib second line. And I think that the definitions of steroid refractoriness and steroid dependence are very well established. But what I was wondering, because of course we are all very well aware of the steroid toxicity, what does it actually mean for you? So when do you, to maybe very practically, who would you declare as a steroid intolerant person, and would that when it would force you to move on to second line? So that's my first question.
I'll give it a shot. So your question is, who do we clinically call steroid intolerant?
Yes.
So that suggests a toxicity from steroids for this, and given that steroids are first line, as we all accept, I mean, there's for us, a very high threshold to call someone steroid intolerant. So what would that be? I think the one thing would be if they went psychotic. All right. So steroid psychosis, where you can't take care of the patient, would certainly be steroid intolerance. And then after that would be possibly if they had really brittle type 1 diabetes that you couldn't control, though with all the agents we have today, that's much less of a concern. Other than that, in the acute setting, I'm not sure who else is steroid intolerant as you're trying to fix. There's a bunch of other steroid toxicities, obviously, but if you're trying to fix the life-threatening acute GvHD, I'm not sure what else is steroid intolerant, at least early on acute. I mean, there are long-term things that we can get into, but early on acute is very rare.
And
there's an occasional, older patient who is, might have come into transplant more robust and quickly is becoming very, deconditioned, weakened, more poor performance status. That patient may be labeled as intolerant of steroids because they're not going to be able to tolerate the steroids for too long, given their overall myopathy and weakness. But I'm not sure they're truly intolerant of steroids, but they may be. Oftentimes when people in practice start steroids earlier, it's that and they're labeling them as intolerant. That's what I see as being the more common scenario.
But maybe can I answer this question by throwing another question? Could it be simply that actually it depends on the patient, and a patient, although it may not be life-threatening, but a patient complaining about a difficult time to sleep and not able, to sleep. Obviously, it's not life-threatening, but definitely this is impacting the quality of life of the patient. A patient who's a diabetic patient, but becomes the diabetes control becomes more difficult or more challenging to handle. Could it be steroid intolerance? I mean, just throwing a few questions, because I don't believe there is a unique or universal answer to this.
Not sure sleep would push me towards starting a next line therapy. Many people have poor time sleeping with or without steroids, and that would be a large percentage of patients, I would fear. And diabetes in general, we can manage it. So I would say oftentimes intolerance is just a term clinicians use to make the case for starting ruxolitinib earlier in their population and maybe getting reimbursement, being able to justify the drug or justifying it with their colleagues, etc.
Intolerance also depends on where you are in the treatment of the patient, right? So it's easy to call someone intolerant when they've had a great response to steroids and you want to taper faster or add something on to spare someone steroids. The definition changes. It's also easy to call someone intolerant when you don't think steroids are working so well and it hasn't reached some magical day number that you use your definition for steroid refractory. So I just think it really just depends, and I agree with Amin. We call them intolerant to generally justify our use of ruxolitinib.
I think the question is, do we have the courage to try to challenge the corticosteroid on these patients? So I don't tell this intolerance. We should never challenge the tolerance of the patient and get rid of the corticosteroids as soon as possible. Since 50 years we are using them, and no one here will say, without corticosteroids, I will be happy. I think everyone is getting rid of corticosteroids, but still helping us. But we now have different agents, different pathways. We have ECP in different stages, but we should never try to challenge the tolerance of the patient and get rid of the corticosteroids as soon as possible. But the tolerance of the patients of the corticosteroids actually, both in acute setting and the chronic setting, is okay. But the side effects is detrimental. Thank you.
This is only my first question, and I have many more, but there is also Stephen and Arnon who want to say something. And just maybe we can, once you finish, we can also move on to steroid taper, because that's the second. And I know that Robert has some interesting, let's say, approach to tapering steroids very quickly. But let's hear Arnon and Stephen first for the first question still.
Yeah, I just echo that intolerance is something very subjective, and it depends if you have a second line treatment or other treatment. So it reminds me about CML and interferon, that suddenly when imatinib came in, or TKI, everybody became intolerant to interferon, had some depression and some other side effects. So if there is no alternative to a drug, then intolerance, we give some supporting agent in order to overcome this, in parentheses, intolerance. And if there is a second line, we are very easy on the intolerance, and therefore I think that this is something extremely subjective. And also in studies, if patients are allowed to go into studies, including if they have intolerance, or the results in patients that are intolerant compared to patients that are really resistant, always the intolerance patient do better. So I would agree with my colleagues that this item is very, 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 very much subjective.
Well, I agree. Of course, everything has been said, and looking at, I've been always fascinating with this love-hate relationship with corticosteroids, addiction and hate. We clearly can do without them. It's a little bit, certainly patient and the clinician dependent. It's acute and chronic setting. It's a little bit different. Just want to say that aspect that fascinates me is that it's in EBMT and US registry analysis that 20% of patients, 20 or 25 with chronic GvHD, get frontline treatment without corticosteroids in current practice. I'm fascinated with this, how people make these decisions, but clearly, there's a strong impetus to stay away if you can, so. Yeah, it's practice dependent, and obviously we have prevalence of opinions in this area, much more than data.
To conclude, I think this is really then I suppose an unmet need, because we do not really agree on what is steroid intolerant, and this is something maybe to be addressed as well. But okay, I think we agree all that we do not like steroids and we want to get rid of them as soon as possible. I think what is really important is how once we said, okay, we do not want to steroids, how do we taper them? Do we use that old way of let's say 20% by week, or do you have some another approach in acute GvHD?
I'd love to hear the recipe of every member of the group, actually.
Yes.
So maybe I can start. There's clearly no standard, and there's no data that would tell us how fast we should reduce corticosteroids. However, my impression is, not impression, but observation over the years is that corticosteroids cause a lot of sarcopenia and increase the risk for infections. And therefore, we aggressively taper the corticosteroids in patients that have failed to respond within 7 days. So we start with the second-line therapy, and then there's some overlap, 2 or 3 days, and then we reduce the corticosteroids by 50%, and then continue after another 3 to 5 days to again reduce by 50%. And then we are often in a range where they're not so toxic anymore. Why do I say that? Because there are data from patients that receive corticosteroids because they had developed immune-mediated side effects after checkpoint inhibition. And the risk to have a relapse increases if these patients take 10 milligrams or more corticosteroids. Significant increase of relapse risk and reduced failure-free survival. And therefore, we try to get in a range below 10 milligrams per day. That's our practice here.
Just make a comment. I'm not gonna give you answers how we taper steroids, because it's again it's sort of like what we think and what we do, it's has huge variation, right? I would say still many centers, at least in the US, try to stick to the speaking of chronic, but both acute and chronic, but the classic, in the chronic Seattle regimen of moving, starting tapering after a week or two, and then trying to move to hopefully to an alternating schedule that rarely happens. But the aspect that Robert mentioned, the second guessing about relationship of corticosteroids and relapse, I'm sort of like, again, perplexed and fascinated with that, because we clearly will all agree that attenuating GVL, it's not a good idea. But really trying to find data that we should give less steroids, when somebody has serious, right? It's hard to find. So again, there's lots of guessing on second guessing on that too. But on tapering, it's in practice, it's enormous variability, and then probably for a good reason. One area where we should probably be more aggressive in tapering is in planning future clinical trials. We know we have already 11 frontline add-on to steroids treatments for chronic, even for acute, that failed. So maybe future trials should really do something about more aggressive tapering if you want to test new agents.
I agree with you, Steve, that probably...
I'm sorry, I can't hear you, Mohamad.
I agree with you that there is no evidence-based data to suggest how you should do it, or what you should do or what you should not. However, more and more, my feeling empirically is that the more is not the better. And actually, while, especially in those patients with severe GvHD, the tendency is to put more or to add immunosuppressive therapy in general. Actually, I noticed frequently that you may actually improve the situation by actually downgrading everything you're doing, not adding another immunosuppressive therapy, maybe decreasing the steroid dosage. Because a patient who has received, let's say, 6 months nonstop high-dose steroids, does it make a big difference to continue for another 7-8 months the high dose? I mean, if you speak to other fields, other specialties, they would say, hey, come on, once you have impregnated the patient, the patient is like a drone in high-dose steroids, why should you continue, the higher dosage? Just a few fruitful thoughts. I don't know whether we will be able to solve this problem one day, but my feeling is that we should push to really decrease, and we won't gain more from putting more or keeping patient on high doses forever.
Okay, I think that's really great, but that's something that can lead us to I think my next question, and that is well, when do you actually, does that mean that we need to evaluate response earlier? Because usually what we do is evaluate response at 1 month in all the trials. That is something that has been the endpoint, but I suppose that all of you do not wait for the response of, for example, ruxolitinib for 1 month, right? There are some new definitions, and also because of those toxicities of steroids, when do you evaluate the response of steroids? Do you wait only 3 days to see if it's working and then move on as well? So that's, I think, corresponds to this same questions, and then we'll move on to ruxolitinib. Mohamad, you have made the definition together with Robert. You can also.
So you're speaking about when we move on from steroids to next line therapy and how long you may wait. I can just speak to what we saw on our prospective upfront trial. We have the randomized trial of AAT versus placebo in the upfront setting. You know, while there is definitions of when someone is, you know, steroid resistant based on, you know, progression after 3 days or no response after 7 to 10, we saw in practice across centers in the United States, clinicians starting next line therapy very early without waiting for those definitions to be met. Very often, you know, 3-4 days after the initial start of their high-risk acute GvHD, the next line therapy was being added. I think, and I don't want to speak for Robert, but I know in his up-to-date guidelines on treatment of acute GvHD, he even calls for the use of upfront ruxolitinib in high-risk cases. And so some people may even do that practice where they don't even wait for them to be steroid resistant if the GvHD is high risk enough.
And when it comes to ruxolitinib, when do you declare does it work or not?
You know, when people in practice decide to use next line therapy and declare somebody resistant to ruxolitinib, often is predicated on how severe the GvHD is. If someone is having, you know, voluminous diarrhea for many days and they're 10 days into ruxolitinib or a week into ruxolitinib, they may go ahead and go on and start next line therapy. Or clearly, if they're developing new organ manifestations, that patient would be declared resistant earlier. You know, there is those definitions of 14 days that are out there, but in practice, it really depends on how severe the GvHD is and how long someone feels comfortable in waiting before starting next line therapy. I would like to believe very few people would wait less than 7 days or after starting ruxolitinib to move on. But again, I think it really depends on the patient in front of you in practice.
Okay, so what I would also like us to comment, because we know that patients with, so when you're talking about the adverse events, so patients with cytopenias and patients with severe infections have a contraindication for ruxolitinib. That's what we say, right? So this is some kind of a guideline. But what does it mean in practice? So what kind of cytopenia would prevent you to start ruxolitinib, and what grade, and also what kind of an infection would you prevent you to start on ruxolitinib as well? Volunteers or?
Well, I think you're right, but again, Zina, I don't believe that for the routine management of ruxo there is like a magic recipe. I think when it comes to cytopenia, it depends on how deep is the cytopenia and how severe. Obviously, we can modulate the dosage of ruxolitinib. And I think people try to play on this. But I agree with you, although we always claim everybody can get ruxolitinib, but I hear several times from different colleagues that actually we're not going to give ruxolitinib for this or this patient. Also, you alluded to the infectious complications. Obviously, in the ruxo randomized trials, there was no difference, but there is still this common belief among many investigators suggesting that with ruxo, you would see more viral reactivations or more infections. So, of course, we rely on randomized trials and there's no difference, but obviously, has it to do, for instance, with cytopenia, which may favor this or this infection? I don't know. Florent has raised his hand.
So yes, two comments regarding for the infection. Of course, if you are worried about infection, what will be the alternative to the ruxolitinib? Because most of the other treatment will also increase the risk of infection. So as Mohamad said, in the randomized clinical trials, there are no differences. Regarding the cytopenia, we have also some patients I'm thinking of acute graft-versus-host disease, when we start the ruxolitinib and there is some cytopenia, and we see the cytopenia that improves with ruxolitinib because it was related to the graft-versus-host disease. So in fact, in most patients, even with cytopenia, I will start the ruxolitinib at the standard doses and I will decrease later on. Because in some patients, cytopenia are truly related. Of course, if this is a patient with truly well-defined poor graft functions, and you know that the cytopenia are not related to graft-versus-host disease, I will avoid the ruxolitinib. But in other patients, when you have the cytopenia at the same time of the graft-versus-host disease, I will use ruxolitinib with no doubt.
Okay, perfect. Thank you, Florent. Does anybody want to add something or should we move on? I have one last question for acute and then we can move on to chronic. Okay, so, well, actually, my last question on acute, since we are talking about the adverse events of drugs, well, do you also, let's say, think of the side effects of other drugs? So we, for example, know that especially in intestinal GvHD, some of the some of the side effects, or for example, letermovir, magnesium, mycophenolate, that also could be worsening of diarrhea. So when do you evaluate the, let's say, effect of the drugs that we think are the main actors here? Do you also think of these things? Do you also think of malabsorption, nutrition, some of the other things, let's say all the other drugs and all the other supportive care that can be taken into account as well here?
Okay, maybe I comment on that. So I think this is a very important point of discussion, because sometimes the acute inflammation is over, but there's still, the patient still has diarrhea and has malabsorption and the albumin levels not going up and so on. So the question we have to ask ourselves is, are we maybe even provoking this diarrhea by magnesium or other interventions? I mean, there are clinical signs that are really suggestive for acute GvHD, like abdominal cramps and abdominal pain, and of course bloody diarrhea. I think we will probably believe that it's more acute GvHD. But we should rule out these other reasons. And if there's a patient who has not abdominal cramps and is doing pretty well except for the diarrhea, then we should, in my view, also think of regenerative approaches. And there's a study that I just completed where apraglutide, GLP-2 analogon, was tested as an add-on to ruxolitinib in steroid-refractory patients. And the observation is that the response rate is on day 28 equally high, but it doesn't decline. There's no additional immunosuppression, but it helps the healing, and the response rate is maintained until day 91, which was the last time point measured. in these patients, indicating that maybe we can avoid a loss of response when we rather help regeneration instead of adding more immunosuppression in patients that have overcome the acute phase where the massive inflammation is controlled, but that have still an epithelial defect that provokes the diarrhea. And I think this might be a future approach that might be worth testing.
Yeah, I completely agree with you. So one is the repair of the intestine and the other one is dysbiosis. I think these are the two probably things that we will think about in the future, because I think we already have drugs that are pretty effective. And while doing that, I think we should also think of the toxicities of the other drugs that we are giving with, let's say, the main immunosuppression, because they can also cause some of these side effects. Okay, well, we can maybe move on to chronic GvHD. Maybe we have like a few more minutes for chronic GvHD, right? Because I haven't seen the schedule at the beginning. But in any case, obviously I cannot show you my slides, but we know that in chronic GvHD today we have 3 drugs approved. So the field has changed extremely. And now when we have 3 drugs approved, how do you, let's say, taking into consideration the adverse events that they have, do you have, let's say, an approach? How do you choose one drug over another, taking into consideration how do they work and what are their side effects? So, well, actually, let's maybe start from ibrutinib. Do you use ibrutinib in your patients? Because we know that it was mainly discontinued in the past due to the adverse events. My experience with ibrutinib is not just the infections and pneumonias. I've seen some severe bleeding problems with in these patients. So I wanted to ask you maybe first about ibrutinib. What is your experience?
Maybe I can jump in. I think you're right. Ibrutinib has been approved based on a small single-arm phase 2 study in the US for chronic GvHD, and the results were quite interesting in the cutaneous and mucosal localization. However, my best guess, and according to the most recent surveys, actually, ibrutinib is rarely used these days, and obviously the community has a large experience with ibrutinib given its wider use in chronic lymphocytic leukemia, mantle cell lymphoma, and other B-cell malignancies. And you nicely alluded to the different side effects, including some arrhythmia and cardiovascular side effects, which makes management a little bit difficult, especially in patients receiving high-dose steroids. So I don't believe ibrutinib is a big matter of concern. And recently, for instance, in France, we were looking into a series of patients who were heavily pretreated for their chronic GvHD with different lines. And actually, only a couple of patients in many years received ibrutinib. So I think today the big debate or the big advance has been, first of all, the wider use of ruxolitinib, thanks to the REACH3 trial, which led to its approval, led by Robert Zeiser and colleagues. And more recently, the advent of belumosudil. Obviously, there are other drugs which are not yet approved. So my feeling is that today the field is moving towards positioning ruxo and belumosudil. And today, obviously, ruxo is approved in Europe. Belumosudil is not yet approved. It is approved in the US. So I'd love to hear the practice in the US. How do we choose between belumosudil and ruxolitinib? But I think in a European environment today, ruxo has been proposed as a first option for the steroid-refractory chronic GvHD.
Yeah, maybe if anyone wants to add something on when there is the possibility of choosing between those drugs and taking into consideration also the adverse effects of these drugs, that would be great. Maybe Amin or Robert or Arnon.
I'm very much in agreement with what Mohamad just said. We have hardly any experience with ibrutinib. There are few centers in Germany that have used it from time to time. Overall, the data are not so strong, and the toxicity is considerable. And Ruxo, it's in the guidelines, it's reimbursed in Germany, so it's our standard. But of course, there are patients that are either not responding or that cannot be treated because they have massive cytopenia. That's more in the acute setting, so than in the chronic GvHD patients. And of course, it will be very interesting to see which new drugs are coming. Belumosudil has been mentioned, seems to be relatively non-toxic and still highly effective. Axatilimab is in the pipeline, and ECP as a combination partner is interesting. But our standard is ruxolitinib in second line.
I can answer or follow on some of that. I too don't use ibrutinib too often, but I am always fascinated by increasing data. I know Joseph Padala presented at the TCT meeting of real world data on ibrutinib and looking at response rates and toxicities, and the data was encouragingly consistent with prior reports, the small phase 2 data, and was well tolerated. And then you have the upfront data with ibrutinib, where the toxicity rates between those who got ibrutinib in the upfront setting with steroids versus steroids and placebo, there was no difference in the AE events between the two arms. So there may be some inherent biases that ibrutinib causes toxicity more than then may actually exist. Patients often have fatigue because of their chronic GvHD or prior therapies, and that may be attributed to the drug. But to answer your question, I personally would we use here more ruxolitinib and belumosudil. How do we decide between the two? For the most part, although we're not always beholden to follow the indication of, belumosudil is approved for a third line setting. Typically, we do follow that strata and go with ruxolitinib. If a patient has had prior ruxolitinib exposure in the acute GvHD setting and then went on to develop chronic GvHD, we may be more inclined to start belumosudil in those. In terms of toxicities of either drug, as Robert said, cytopenias tend to be less of a problem in the chronic GvHD setting, although you can occasionally see it in patients. Belumosudil, a very rare patient will have GI intolerance in the form of poor appetite and nausea. The reported incidences around 10% in the trial, and that's held up true in my experience with the use of the drug. Occasional patient will have that, and sometimes it's quite profound and they need to come off. Headaches occasionally are seen, but the drug has been very well tolerated, and efficacy, I have seen efficacy in my patient population.
Thank you so much. I mean, we appreciate the experience. And I think the last question would be, of course, both of those drugs produce partial responses. It's attractive to combine maybe with ECP because ECP does not cause any side effects. However, what about the combinations of those two? Do you have any experience? Does that increase the toxicity? So the belumosudil and ruxolitinib, and would you do it? Or would you lose one and then start another?
So I can take this one. I think that so far we don't have any data that support to combine ruxolitinib and belumosudil in the clinical trial. In fact, all patients must have stopped ruxolitinib when they start the belumosudil. And in fact, if the patient failed to ruxolitinib, what is the point to just keep going on with ruxolitinib and add another drug will increase the toxicity. And in fact, in some patients, we're able to treat a few patients with belumosudil with the early access program in France. And we are a bit worried just to stop directly ruxolitinib and start belumosudil. So a few patients receive ruxolitinib and belumosudil at the same time. And in fact, we see a lot of infectious complications in those patients. So I have also some data just to say, just don't do that. And just maybe you can have both of them for a short time, but a very quick decrease in the ruxolitinib doses before keeping the belumosudil.
Okay.
Zina, I think that there are some data of combining from, there was an abstract and maybe somebody from our American colleagues, because Zaharia published an abstract on real world in which they combined, belumosudil and ruxolitinib, and as far as I remember, there was no more side effects. So I would say this is possible. And in Israel, we are using mainly ruxolitinib and ECP. The belumosudil was just approved a few months ago, and in patients with lung GvHD, of course, according to the encouraging data, we try to sometimes to change to belumosudil, but really experience is just emerging or piling. Thank you.
Thank you so much. It was really a great pleasure. Yes, and of course it becomes attractive when we have partial remissions with both. So then you would think that maybe we can combine them and to have better response. But okay, that's something to be seen in the future. It was a great discussion. For me, it would be great to continue, but we can't, I'm afraid. So I think we have to wrap it up for the adverse events and drugs. And then I will go back maybe to Mohamad to give the final word.
No, thank you very much, Zina, and thank you all for really lovely discussion. I personally learned a lot, but what it's clearly highlighted that we need more and more of these discussions because there's nothing standardized, and it highlights the complexity of the patient we manage with acute and chronic GvHD. Obviously, we are all fortunate that we're talking now about the new agents, whether in acute or chronic GvHD, and this is definitely very good news.